Hello, good morning, good afternoon, and good evening, everyone. Welcome to this session on optimizing and supporting the community health workforce through gender equity. We'll be hearing some very exciting findings of gender analyses of policies and practices in 3 countries, Zambia, Niger, and Mozambique. So thank you very much for joining us. We have a fabulous panel of speakers who also happen to be my colleagues at the UN University International Institute for Global Health, and I will introduce them in a second. Just a quick reminder to everyone that you're also welcome to please use the on-air side of things if you want to type in any comments or Q&A questions during the discussion. I will just start off with a quick introduction, and then I'll hand over so we can get into the juice of everything. My name is Michelle Remme. I work at the UN University, where I lead our research pillar. And we currently have a focus on gender and health in the research that we do. The UN University is a think tank within the UN system, and our institute focuses on global health. Our gender work is currently launching a gender and health hub, which I just want to mention here because this work also is part of that effort. This hub is meant to be a platform for knowledge sharing, evidence generation, and policy engagement on what works in promoting gender equality in health programs and health policies. So please have a look at it, genderhealthhub.org. We're current and join us and sign up for when we go live early next year. So this session is very much focused on the community health workforce. We all know community health workers play a very central role in ensuring access to primary health care and health information across diverse health systems and country contexts. They've been considered to provide services and be an effective strategy to address the acute human resource shortages across health systems and to extend coverage to rural areas, contributing to progress towards UHC by 2030. And of course, in the present COVID-19 pandemic, community health workers have been key to ensuring that communities were well informed about both the modes of transmission and effective preventive behaviors. Now, if we look globally, the profile of community health workers is highly gendered. So there are, of course, regional differences. In some settings, the majority of community health workers are women with low levels of formal education and are often poorly paid. In other settings, it can be more skewed towards men, but promoting gender equality within the community health workforce is an opportunity to address the biases and the inefficiencies in the workforce and actually maximizing the impact and the effectiveness of community health. So addressing gender inequalities through the community health workforce policies and programs is really an essential step in this process. And this is what this session is focusing on. So we will have colleagues presenting the results from a project that is looking at these 3 countries, Mozambique, Niger, and Zambia, and has examined country policies and programs for the community health workforce, how they've been implemented, their effectiveness in improving work conditions, and the contributions towards gender equality outcomes. So we'll be sharing evidence on the case for promoting gender equity in the community health workforce to optimize service delivery. So the purpose here is to present and discuss the evidence on how existing community health worker policies can be strengthened or new policies could be designed to ensure that they promote gender equality. To contribute to an understanding of how gender-informed policies and practices in community health can be a transformative pathway to strengthening primary health care and progress towards UHC, and also to spark interest in the development of methodological approaches to incorporate practically gender within health systems, building blocks more generally. So I will very briefly, because I'm sure you want to hear from the speakers, I'll just very briefly introduce them and then hand over to them to take over from here. So we're starting off with Dr. Joanna Riha, who is a research fellow at the UN University and has been working on the gender analysis policies and practices of community health workers in this project. Yeah. She holds a PhD in epidemiology from the University of Cambridge, an MSc in epidemiology from the London School of Hygiene and Tropical Medicine, and a BSc in biology from the University of Birmingham. So she'll focus on the findings from Zambia. Then we have Dr. Paula Morgallo, who is a medical anthropologist with a PhD in African studies. She's been working for several years on gender studies on the topics of Islamic feminism, conjugal dynamics, migrations, and reproductive health, with a focus on West Africa and in the Nigerian society. She's strong expertise in ethnographic research to understand community health and healthcare as shaped by global historical forces and local contexts. And Paula's been leading the work on Niger. And last but not least, Dr. Claudia Lopez, who's a research fellow at UNU as well, based here in Malaysia. She led this overall project and has been working with UNICEF, national advisors, and local partners to see it through. Her research interests focus on community health, community engagement, and the gendered aspects of digital technologies. She is a social psychologist with over 20 years experience in quantitative and qualitative social research in academia and media for development organizations. So she holds a PhD in social research methods from the London School of Economics, and she will be presenting Mozambique. So that's probably enough from me. Just a quick reminder, please do feel free to type in your comments or introduce yourself and any thoughts or questions you have in the on-air platform. And I will now hand over to Joanna.
Great, thank you, Michelle. Thanks for the introduction, and thank you everyone so much for joining us. It's great to see, such a vibrant group ready to go, and I think it'll be an exciting satellite session, and I'm looking forward to a lot of the discussions that are going to come out of the presentations that you'll hear over the next 2 hours. So I'm just going to share my screen as I'm going to present, so bear with me 1 second. So Michelle sort of set the scene in terms of giving the background with regards to, why we're going to focus on the community health workforce in particular, and I'll touch on a couple of those points. But I'll largely be focusing on presenting a bit more information about the project background, specific objectives, and the methodology in this first presentation. We'll then have about, I think, 10 minutes, maybe 15 minutes if I'm quick and on time, for a discussion. Followed by a next presentation, which will then really focus on the results from Zambia and the Zambian case study. So really, I thought it's worth, I know Michelle touched on it briefly, but I thought it's really worth reinforcing the point why it's important to focus on gender with regards to the community health workforce in particular. I mean, it's clear that in order to achieve the Sustainable Development Goals, which includes universal health coverage and health equity, it really requires a health workforce that's fit for purpose. And that involves, resources, training, but also in terms of a workforce that's valued and respected. There are clear inefficiencies that are costing the global health economy billions of dollars. And this is, related to the human resources for health element in terms of skill mix, attrition, retention, maldistribution of health workers. And one of the key factors in terms of some of the drivers of those inefficiencies is actually gender equality. And I think this is really why it's critical to hone in on this as an aspect to begin to address some of those inequalities with the vision of, achieving universal health coverage, for example. So why the community health workforce in particular? As Michelle mentioned, they are actually the largest group within the frontline health workforce. And in many contexts, actually the only point of contact for communities, with the healthcare system, particularly those who are the most vulnerable or hardest to reach. And I think that's really something to consider when we're thinking about health equity. And as Michelle mentioned as well, it's a highly gendered workforce, although I think it's really important to note that the gender composition does vary quite a lot geographically. I mean, for example, across sub-Saharan Africa, the gender composition in terms of men and women within the health workforce is slightly more balanced, whereas in Asia, it's a predominantly female workforce. But as you'll see from some of the findings that have come out of the project, this is a point to consider even at a subnational level. So just to summarize in a neat way, I think there are really three main gains in terms of investing in gender equality within the community health workforce. There are gains with regards to health in terms of improving service delivery. For example, incentives for relocating community health workers to rural areas might be different for men and women, and addressing those differences and catering to them will result in better distribution of the community health workforce in these areas, as well as catering to the needs and preferences of the users. So thinking about the gender of the provider and how that might affect uptake of services. There are the economic benefits, which I touched on in the last slide, and obviously there's the critical one of women's empowerment in terms of empowering female community health workers through improved access to resources, knowledge, training, gaining economic independence will also have knock-on effects to their communities. So the project really starts from the point of trying to answer this question: how, given we know all of this, how can we really support governments to create more gender equitable policies in relation to the community health workforce? And we found a really valuable platform as an inroad for this work, and this is the Community Health Roadmap, which I'm sure a lot of you are aware of. It was a platform launched in 2018 across 15 countries, and is a platform to really elevate national priorities for community health broadly. So it's not just focusing on the workforce, it's community health overall, and is very much a country-led process of identifying key areas or priorities. And there are three sort of overarching goals or aims of the roadmap, bridging the gap with regards to survival, with regards to equitable access, and the final one is bridging the gap in thriving. And that one explicitly mentions gender empowerment through female employment as a factor. And this is really that entry point for our work. And as I mentioned, with the roadmap, it's very much country-led. And so we picked 3 countries that had already identified gender as a priority with regards to community health and their plans for community health in the near future. So Niger, Zambia, and Mozambique were identified for various reasons. I mean, here are some quotes with regards to some of their, I don't know if I'd call it reasoning, but in terms of their priorities with regards to gender. So for Niger, it was ensuring a participatory and inclusive process, particularly focusing on gender dynamics in terms of the implementation of interventions, the development and implementation of interventions. With regards to Zambia, it was looking at a gender-sensitive community health care and how that is implemented with communities to improve health. And in Mozambique, it was strengthening the recruitment and selection of community health workers with a focus on gender and level of education. So you'll see how these also come out through some of the findings that we'll present a bit later. The project overall has 3 specific objectives. The first is to support the countries and key stakeholders in terms of advancing gender equality within the community health workforce, with a view to ensure equitable access and improve health outcomes. The second is to identify and share best practice on evidence for promoting gender equality within community health worker policies and programs. And this is really with a view to how can this best evidence and practice be adapted and contextualized in other settings. And the final objective was to develop a methodology that would be validated by the 3 country case studies for broader application and dissemination. So in terms of the framework and methodology, the gender analysis framework and how we set this up was really thinking about, first of all, the key sort of structural and intermediate determinants of gender inequality. Right? So what are the differences in the level of power that men and women community health workers hold? And to categorize that, we've used 5 key gender domains, focusing on roles and responsibilities. So roles and responsibilities of men and women in society, their access to assets, needs and priorities, beliefs and perceptions, and then finally looking at institution laws and policies. And we then mapped this, given we're focusing on human resources for health and a specific subgroup of the health workforce, we wanted to explore how these differences in power then affect the community health workers' opportunities and decision making in relation to 8 human resources for health domains. So that's related to the selection criteria and entry requirements, the process for recruitment, training, deployment, roles and responsibilities as a community health worker, as well as remuneration, supervision, monitoring, career progression. This will become clearer as I talk through the next couple of slides, and as you'll see the results presented a bit later, if it's not clear already. And this analysis framework looks like this sort of 2x2 table and is very much influenced by work that Rosemary Morgan did, and I believe Rosemary is actually on the call if I'm not wrong. So the idea is to then populate specific questions at these intersecting sites. So with regards to roles and responsibilities that might affect selection and entry requirements of community health workers, and how women might be disadvantaged in terms of access to education and therefore might not meet the entry requirements to become a community health worker or be enrolled. So it essentially looks, I mean, it's a very detailed table, and the idea behind this gender analysis framework is the detail. The intention is to really unpick what are some of these key elements and key structural and intermediate factors that affect these different human resources for health domains with regards to the health workforce, right? And the idea is to inform the research. The view is not that this framework will be used by policymakers, as it is extremely detailed, and I don't think people will necessarily have the time to go through each of the elements, but it's really to inform and enrich the research that we are doing for this particular project, and then we will develop a more refined and simplified version for future use. So in terms of the methodology itself, I've given a background in terms of the framework. There are three main stages of work, if you like. The first is very much a content analysis of policies. So we are looking at what community health worker policies exist across the 3 countries. Do these policies consider gender in relation to the community health workforce and in relation to the human resources for health domains and some of the other gender domains that we had highlighted in the slide above? So the source and tools for that is it is the national policies. And we are actually using 2 tools. We decided to use 2 tools to do this content analysis. The first one is the WHO Gender Assessment Framework, which I'll explain a bit more in the findings slide for Zambia. And the second is the detailed gender analysis framework that I just presented a few slides ago. The plan is then to move on from this content analysis. So we understand, we get a view of what already exists, what policies were developed, how and if these policies consider gender with regards to recruitment, with regards to training, with regards to remuneration. And then the plan is to link, and this is a really critical step, is to link the policies to the gendered realities, right? And here the aim is to answer the question of, how have these policies been implemented at national and subnational level, and how gender equitable are these policies? I think in order to be able to say whether policies address gender inequalities, we have to understand what are those inequalities, what are the barriers, what are the challenges that men and women face within the community health workforce, right? To be able to say this is how policies need to be developed to be able to address those challenges. And so the source and tools for that are focus group discussions with community health workers in rural and urban areas, as well as key informant interviews, looking at sex disaggregated and age disaggregated community health workforce data if available, and again, doing that analysis using the same gender analysis framework I presented earlier. And finally, the plan is to identify the opportunities based on the findings from the previous 2 steps, is to identify the opportunities for policy strengthening, right? So how can existing or emerging policies be strengthened to ensure that they are gender responsive or gender transformative and address some of these issues that were raised when we were looking at the link between realities and the policies. So the information is very much gathered from the previous two steps, and one plan was to use the gender equality continuum as a guiding tool. And I mean, I think there are pros and cons to doing this, and we are, in dialogue about how to progress. But I think that's the vision. And then that will be, from that, we will then develop a tool, or at least the draft of a tool that can then be tested and contextualized in other settings to move this work forward beyond the 3 case studies. So I think I will stop there and maybe take questions. Actually, maybe I'll keep the presenter view on. And we do, sorry, can everybody hear me? Very quiet, it's a little, I hope you all heard me. I mean, I don't know if there are specific questions. I mean, maybe we open it up. Michelle, I don't know if there were any in the chat.
There's one question from Mary Adley. Did you look at the cultural norms and values that influence the willingness or appropriateness to provide community care?
The cultural norms and values for, I mean, so at this stage, and I mean, I haven't outlined this. At this stage, each of the individual country case studies, if you like, are at different phases of completion. Zambia and Mozambique, we've very much completed step 1 in terms of the content analysis. And in the case of Mozambique, actually begun part of step 2, looking at disaggregated data. And I think where we can speak a bit more to that specific question with regards to looking at cultural norms and values is findings from Niger, where we have begun very much to explore cultural norms and values within communities that the community health workers come from. We have started doing some of those interviews, and my colleague Paula will probably speak more to that.
We have other questions, Joanna. So from Rosie Stitch. Hi, Joanna, thanks for the presentation. My question is how you plan to disseminate work on STUN, and to what extent policymakers have been involved in the project so far, because this will be critical to getting changes into policies. And
yes.
And another question for Mary Hadley. Did you look at the cultural, it's Sarah Jeffrey. Thanks for the presentation. Is there significant differences in the remuneration strategies between the countries for community health workers? And if that differs between male and female community health workers?
Okay. I mean, with regards to the second question from Sarah, maybe if I may, can I ask that we keep that one on hold, just because I think some of the findings that we'll present in the next section will speak to some of those differences. And I think Paula in particular will probably be able to talk more about, you know, the lived experiences of the community health workforce, because it's one thing on paper and I think another in practice in some instances. So maybe I can touch or refer back to Rosie's question with regards to plans for dissemination and engagement of policymakers. It's a very good question. And we are working closely with the Community Health Roadmap team in particular. So the view is to use those existing networks to be able to engage policymakers that have already been involved in that process, right? And have already identified gender as a priority area. And so it's sort of a an easy entry point, if you like, for those countries. The plan is to work with the remaining 12 countries, I believe, in the Community Health Roadmap, and look at more broadly, as this project is funded by UNICEF, look at opportunities with country offices to explore how the tool could be taken up. But that's very much sort of a later stage, although I definitely appreciate the point that it's important to engage them now in terms of buy-in, if any changes is going to be implemented.
We don't have more questions, Joanna, if you wish to continue.
Yeah. Okay, 1 second, I'll just go back to screen share. Sorry, it's gone back. Okay, so, and Sarah, I will keep your question in mind and touch on it. In terms of the results, as I highlighted earlier, across the 3 countries, we're at slightly different stages of data collection and finalizing the project. Overall, in terms of work to date, there are a few, well, there are commonalities that have already started to emerge. I think it's clear we did a very lengthy background review with regards to the community health workforce and looked at literature that has been published with regards to the community health workforce in each of these countries. It's, you know, the consistent element there is that there are 2 main groups within the community health workforce in Niger, Mozambique, and Zambia. There's a paid formal group and a voluntary informal group. And there are gender dimensions and differences between these 2 groups, particularly across geographical areas, urban areas versus rural areas in particular. I think it's also worth noting that there is a much longer historical context to the community health system, and I think Paula will also touch on this. And this also influences, you know, the status, for example, of a community-based volunteer that, you know, historically might have been a position where an individual within the community might have a slightly higher sort of social ranking or be held in higher esteem by the community and therefore given this voluntary position, even though it is voluntary. So there are elements to consider there historically that affect the current context. And governments have largely been trying to focus on integrating the more informal voluntary group into the formal health system. And I think this is proving very difficult. I mean, some of the elements will appear in the findings that we present, but there's just such a variation within this voluntary group of community health workers in terms of training, in terms of even remuneration, and being able to streamline this group and really effectively integrate it into the formal healthcare system is proving difficult, and I think very much requires looking at some of these issues with a gendered lens. Finally, just based on our review of policies and strategies that we have had access to so far, most of them do not consider gender explicitly. And as I mentioned, the evidence from Niger will make that link between the policies and these gendered realities. With regards to recruitment and career progression, we identified those as 2 potential areas of focus. So given, you know, we were looking at the breadth of 8 human resources for health domains, we identified these 2 as potential areas for focus and future work. You know, again, it would need very much to be country-led, but based on the evidence thus far, to focus on with regards to tackling gender inequalities in these two human resources for health domains. So, findings from Zambia As I mentioned earlier, across all 3 countries, you have these 2 main groups within the community health workforce. In Zambia, they're called community health assistants, is the more formal group who receive training. They're formally employed by the Ministry of Health. I think 2,500 was the last estimate I saw that had been trained, and about 2,000 are employed. And the view was really to scale up this subgroup of the community health workforce and train up to 5,000 by 2021. In terms of data with regards to the gendered composition, what we were able to find is, I mean, in terms of trainees, at least half of the first and second batch of trainees of community health assistants were female. How this translates into employment and retention is a question. With regards to the community-based volunteers, they may receive some training, although it's highly varied and dependent on the program that they're working on. They work on a voluntary basis, although they do tend to receive some form of remuneration for their work. I mean, this can be, you know, a bag of rice or a t-shirt. It very much depends on the project. Until recently, there was no central coordinating mechanism for community-based volunteers in Zambia. And figures in terms of estimating the size of this workforce varies. And I mean, estimates range from 23,000 to 100,000. And there is some sex disaggregated data that is available, which indicates large variations in the community-based volunteers in rural areas compared to urban areas. So those in rural areas are predominantly men, whereas nationally, if you look at the community-based volunteer workforce, it's predominantly female, just a bit over half. So in terms of this content analysis of policies, Zambia has published very recently their community health strategy. And it does recognize gender disparities in terms of levels of education and gender-based violence, and talks about delivery of a gender-sensitive community health care as its vision. The strategy does highlight some of the gender differences in terms of focusing on outcomes with regards to inequalities, but what it doesn't do is make the link with the underlying social norms or practices that might be driving these inequalities. And in terms of a more gender responsive approach, the community health strategy focuses on 2 main areas. Firstly, developing community sensitive service provision at community level, and the second is focusing on addressing gender disparities in, again, the volunteer group, the community-based volunteer selection. But the strategy does not provide the details of the processes that are needed to improve selection and recruitment, for example, or particular mechanisms that would need to be in place to address some of these barriers. And so we're really hoping that with the next step of the work, linking, you know, the policies to the realities, we're also able to find out more about what guidance documents do exist that might already be addressing these issues that we haven't had access to, and begin to really understand more holistically how this community health strategy and supporting documentation might be addressing these issues. So just to present some findings with regards to the first tool that we used to do the content analysis, which is the WHO gender assessment tool. Just to provide a brief bit of background, you know, the gender assessment tool is really intended as this very rapid assessment tool. It's not going to provide, you know, provide a researcher or a policymaker with the kind of details in terms of, you know, what specifically does an existing program or policy need to address or change. It's really a starting point to look at sort of the gendered responsiveness of a given policy or strategy. And the way the gender assessment tool is structured is there are 23 questions grouped into 2, and depending on whether you answer yes or no to some of these questions, and the number of positive or negative answers, you then group the strategy or policy as being on the gender continuum of gender blind, gender sensitive, gender responsive, or transformative. And based on this, I mean, I could go through some of the questions, but I thought rather than spend time doing that, I would just briefly summarize, if we do use this very quick, rapid assessment tool, it would categorize the community health strategy as being somewhere between gender blind and gender sensitive. For example, the strategy didn't explicitly state whether the Ministry of Gender and relevant gender focal points or partners with a gender expertise were part of the group of stakeholders that were consulted during the development of the strategy. There was no explicit mention of the roles and the balance of the roles that men and women played in the decision-making process within the group that did decide, but also I think the consultation. We have to think from the project's point of view, the community health workforce. How were they consulted, and was this gender balance sought and power given with regards to decision making? It was also unclear how the integration of traditional government structures would affect gender equality with regards to decision making. And again, that ties in broadly to policy development, but also will affect, for example, recruitment of community health workers. So now I'm going to briefly go through in a bit more detail, and we can stop if there are questions. I mean, I've got quite a few slides here, but I wanted to highlight, our findings with regards to what do the policies say with regards to the human resources for health domains. So, selection requirements, training, etc. And how does that link back to our gender analysis framework? So, for example, for the community health workers, I hope you can see, I'll try to use my mouse to point. So for the community health workers, for example, the entry and selection requirements for this group, they must have completed their O-levels, and there is actually an upper age limit, which is interesting and worth noting, and I think something we'll pick out in the gender analysis framework and some of the questions. They have to be endorsed by these neighborhood health committees, and the neighborhood health committees actually do the personal interviews and are involved in the selection process. So given that's the information you sort of get from the strategy itself, if we're looking at it with a gendered lens, and given the background research that we've done, these are some of the outstanding questions we would then want to unpick and tease out through the fieldwork, through the focus group discussions. So, So given the selection criteria and entry requirements, I mean, there is a lot that has been published in terms of gender disparities and levels of education in Zambia, particularly with regards to girls in rural areas having much less access to education. And do the entry requirements automatically disqualify and discourage women from applying? We also should think about, are women less likely to apply due to their marital pregnancy status or family responsibilities? And also, does this upper age limit exclude older women who might have fewer social limitations, but actually have the experience, the valuable experience with regards to community health work, but because of that upper age limit, they're excluded? And then questions around, who makes up the neighborhood health committees and how do they uphold these social norms and beliefs that may discourage women from joining the workforce? I mean, with regards to the comparison between the community health assistants and the community-based volunteers, for these paid jobs, the formal paid jobs, given they might have a higher social status, are these jobs largely reserved for men, even though a policy might explicitly state, gender parity with regards to recruitment. So I think these are some of the questions that have come up. With regards to training, again, community health assistants have to undergo a 12-month training, and it focuses on a whole breadth of areas, including the healthcare system, behavior change, environmental health, diagnostic procedures, management of comorbidities. And again, how does this 12-month training, and you have to sort of sit through the 12-month training in one go, how does that discourage women from applying due to, family commitments, their marital status, pregnancy, for example? And as part of that, it's also worth asking, are the community health assistants taught about gender equality within the workforce and avenues to report gender discrimination within their post as part of that training, right? So that's another element to focus on and explore further. With regards to provision of services, the community health workers offer a range of services in Zambia, centering largely on health promotion, disease prevention, primary health care. And it's said that community health assistants must spend about 20% of their time in the health post and 80% of their time in the community. However, based on the research we've found and documentation to date, it's actually the opposite that's the case. So this paid group are spending less time in their communities and more time in the health posts, given a more general shortage of healthcare staff, of healthcare professionals to staff these health posts, right? And that in turn has a knock-on effect on the community-based volunteers who are supposed to be managed by these community health assistants. With regards to supervision, community health workers are supervised by whoever is in charge at the health post, usually a nurse or environmental health technologist. However, they're often alone working unsupervised. And again, there are gendered questions there in terms of support and safety and, issues that may arise with the communities that they're working with. What support do the health workers have and the community health assistants have to be able to handle that? And given there's likely to be a gender dynamic to that, if they feel they're completely unsupervised and working very much alone, perhaps that's a disincentive to work in these rural areas where they have very little support. So, I won't go through all of the questions, but it's just to demonstrate sort of where we are at. And I know this might seem a little bit overwhelming, and we're hoping that through the focus group discussions with the community health, assistants and volunteers, key themes arise and priorities, self-identified priorities with regards to the structural and intermediate determinants of gender equality emerge, and those can then be highlighted as specific areas to focus on. But at this stage, we didn't want to narrow it down without having related directly to those realities. So I think maybe I'll skip ahead and just quickly sum up, and then we can have, I think, 15 minutes for questions and discussion. Some of reflections and next steps. One thing that the WHO Gender Assessment Tool highlighted is, we need to be thinking about women in senior leadership positions involved in policy and strategy development in relation to the community health workforce, also thinking about integrating the voices of the community health workers into the policy development and ensuring a gendered balance there. And also, I think, how do these policies translate into practice? And I think that's where we're very much eager to begin the next step. And with that information, we will then be looking at, given this strategy already exists, it's not it's not in a context where a new strategy is being developed. Given this strategy, community health strategy already exists, how can it be further strengthened? What are the inroads to further strengthen it? and some of the processes involved in that. So with regards to next steps, we're currently working with country advisors, and I believe they're on this call, I hope, and they can please do feel free to chime in as we're presenting our findings and results, to link these policies to gendered realities, as well as explore, sex disaggregated health workforce data where available, and as I mentioned, really expand the analysis and identify, country-led priority areas and community health worker-led priority areas. So yeah, let me stop there. Thank you.
Joanna, there are some questions in the chat. Would you be able to answer those questions?
Yeah.
Okay, so
Sorry,
there's...
I haven't looked in the chat.
Yeah, okay. So there's one question from George Atim. The experience from Zambia is quite similar to Mozambique. Gender inequality in favor of men is there. Do you know whether the gender discrepancy is similar across all Zambian provinces, and any specific orientation from government to reduce these imbalances?
Sorry, Claudia, I missed the last part. In terms of whether it's consistent across the country, in terms of these gender
different provinces, yes. And if whether there's any orientation from government to reduce these gender imbalances.
Actually, it's Baltazar Chilondo. Sorry, I signed with different name. Thank you.
Okay, sorry, Baltazar. Yes, thank you. And there's other question from Mary Adley. Zambia has a multitude of community workers hired through the vertical programs, and the TBA, CBD, HIV home care volunteers, and so on. So whether the CHC hires a CBW are candidates from this cohort.
Sorry, I missed that because the connection. I can look at the question. Sorry.
You can start answering the question from Baltazar if there's any gender imbalance across the provinces and
So Baltazar, thank you for that question. And I think the case in Mozambique is, one of the reasons you're able to identify that is because you have the sex disaggregated data and age disaggregated, which I understand, which really helps you to be able to identify these discrepancies. As far as I'm aware, I haven't seen anything comparable in Zambia, but I could be wrong. I don't know, Joseph Zulu is on the call, I believe, and he's our in-country partner in terms of, disaggregated data that might be available. I'm not aware of provincial discrepancies. I mean, what I have read is it's largely this urban-rural. So, yeah.
Okay.
And sorry.
Thank you, Joanna. We can explore that question for the Mozambique case study, and Baltazar can maybe discuss a bit more based on the data that exists for the country. There's also one question.
I see from Mary, is it?
Yes, for Mary.
At least in terms of, so in terms of how community the vertical programs and hiring of community health workers through those programs, whether they then translate into candidates for the community-based volunteers. Is that right, Mary, roughly? I mean, in terms of the community-based volunteers, it's highly program specific, and in terms of criteria for recruitment, it's down to the implementing partner or agency. With regards to career progression for the community health assistants, there is supposed to be a clear plan developed that will allow them to progress into more senior positions. However, this is rarely the case. And again, I don't know, Joseph, if you'd like to jump in or give any further detail with regards to this.
Maybe it's not online.
And I see, Mary, you had another question with regards to comparing the unemployment, underemployment rate between the studies. You mean unemployment of the population at large, or you mean the proportion of trained community health workers that are then employed? Do you want to maybe just speak? It might be easier. Or repose your question, Mary, is that possible? I think you can unmute. No. I mean, we haven't, again, it's, in terms of this question of data that are available in terms of training versus number employed and, retention longer term. And I think that's definitely a major barrier across the board. I think in so many contexts and countries, that level of data is not available, particularly sex disaggregated. Sorry, yeah. Mary.
Yeah, my first question matters. Obviously, you're doing this big study looking at the gender differences in community health workers. So the first question is really, so what if there is? Does it actually matter? Is it actually impeding provision of universal health coverage? And then the other one, though, on underemployment and unemployment is really, there's so much, in a context where there's underemployment and unemployment, then the men will more likely want to go for an opportunity, especially if it's paid. But when the men are in employment, then it's the women that go into to take these jobs, especially if they're voluntary or have a very low remuneration. I just wondered if you'd looked at that as well as the other sectors that have community workers, like the agricultural extension workers, etc.
Thank you for those questions, Mary. And I think a very valid point in terms of your very first question. Are these differences actually a barrier to community health, delivery and universal health coverage? I mean, the thing is, we've begun the project from the starting point that this is a priority area that governments have selected to focus on, and the evidence does exist. I mean, in an ideal situation, you would also, and we had originally thought of having interviews with the communities that are served by these groups of community health workers that we would interview. So it would be looking at the user as well as the provider. Unfortunately, we weren't able to do that, but that could speak to speak to your point very directly in terms of whether service provision is hindered by some of the gender inequalities that exist within the health workforce. In terms of looking at, comparing our findings with other community-based workers, we have not done that. And maybe that's something to consider, further down the line as a more research-based project to look at comparisons outside of the health field, which is very interesting.
And there's a final question, Joanna, that I think maybe it can also be picked up by Paula in the Niger case study. Did you look at the gender breakdown of community health worker supervisors which is skewed in many contexts as well in terms of career progression. I believe we don't have that data for Zambia that we have for Niger.
Yeah, we don't have that level of data from Zambia. And I mean, again, I'm hoping through the field work that this, some of this will emerge in terms of the lived experiences of community health workers saying, look, who are my direct line managers and supervisors and career progression? What are the opportunities and what are some of the barriers? And, what are the differences that come out of the discussions among the female community health workers compared to the men? But in terms of data, we don't have that. We haven't had access to that, and I'm not sure if it's collected.
Okay, thank you very much, Joanna. So we finished the first part of this satellite session. We still have 1 hour to go, but we will suggest that we'll have a short break of 10 minutes now, and we can start again. Let's say 15 minutes. We can start at 2:10 for the other 2 final presentations, the case study for Niger and the case study for Zambia. So please bear with us, and we will stay online, so you're very welcome also to stay online and to continue your discussion in the platform or to pose other questions in the Q&A. Thank you.
Can the speaker please unmute yourself?
Paula, is that your background noise?
Okay, you want me to start?
Not yet, in 5 minutes.
Okay. Okay.
Hello and welcome back. Let's get started with the second part of the satellite session. So we will have a presentation of the case study for Niger by Dr. Paula Morgallo, and then we'll have the presentation for the case study for Mozambique. The case studies presentation will take around 15 minutes, and then we'll have 10 minutes for discussion after each one. And so I will welcome Paula. Paula is in Niamey with a very feeble internet connection, so she needed to go to an internet cafe. So there may be some background noise, but I hope that will be good enough for us to listen to what she has to present. Thank you, Paula.
Thank you, Claudia. Thank you for having me. I'm delighted to participate in the satellite session on community health workforce. I will read my presentation because I do not feel comfortable to speak by heart in English yet, so I am afraid of missing something important. So I'm deeply sorry for that, but okay. Let's start. Next slide, please, Claudia. In Niger, community health workers were one of the most groundbreaking change introduced by the government in the 1960s, which emphasized the need for preventive health care and health education. Actually, nobody knows how many they are, neither how many different categories they can be classified according with the type of service provided. Next slide, please. Since 2008, curative health has been provided by ASC, Agent de Santé Communautaire, thanks to ICCM training. Together with them, RC, Relais Communautaire, have also been trained in key family practice, but once more, data from those RC are scarce and contradictory. Since 2012, ASC have been trained in revised antenatal guidelines as well as in essential newborn emergency obstetrical care too. In 2013, RC started to be trained in ICCM as well. Next slide, please. For this presentation, we will just focus our attention in CHW who provide curative care. At that level, community health system in Niger is structured around a two-tiered system of frontline health workers, paid and volunteer work. Next slide, please. As you can see, like what happens among RCs, cadres, AAC are not an homogeneous among graduate and undergraduate health workers. Graduates ASC need to have at least a technical certificate level in health domain. In what concerns undergraduates ASC, in the first years, a high school level was required, but in the following years, it was just become necessary to have a primary school level. Undergraduate ASC were recruited from their own village. RC need to live in the community and know how to read and write. They also had to be between 20 and 50 years old at the time of selection. At the beginning, unmarried women were hardly selected, but this trend has currently changed. Both married and unmarried women can now be selected. Graduated ASC are recruited through public tender. Ungraduated were chosen by their own village. RC are also chosen by their village. Graduated AAC have at least 2 years training in health domain. In the first years, ungraduated ASC had a 2-month training that has been extended later to 6 months. RC training is around 10 days. As Joanna said, it depends for which program they are working for. Both graduated and ungraduated ASC work at the case santé level, but not exclusively. They can also be deployed at health center or even hospital district level when there are human resource shortage. There are, however, some difference between them. Graduated are deployed where there is a vacancy. Ungraduated usually work in their own village or in the surrounding health area. This doesn't need deployed further from home. Both are formally attached to Ministry of Health, but in the past, undergraduate AAC were attached to the county administration. RC work in their own village. Okay, next slide, please. I think I forgot. Okay. All of them provide promotional, preventive, and curative care and have a managerial responsibilities. RC just provide curative care for children aged 0-5 years old. Both graduated and ungraduated ISC earn 77,000 CFA per month. Female AAC have also right to maternity leave, flexible work schedule during breastfeeding, and 2 or 3 days off when their husband returned from a long-term trip. Recently, RC financial compensation has been increased to 20,000 CFA, but it seems that they are not receiving this amount yet. Next slide. Next slide. please.
Is this one, Paula?
The head of the health center to which ASRC are also supervised by AAED volunteers. Agence Nigérienne de Volontariat pour le Développement. Sorry, you need to come back, please. You need to, sorry? Please, we are in the previous slide, please. Are you hearing me, Claudia?
Yes, I am, but I think there are some interference. Paula, maybe it's better for you just to.
I continue. Okay, don't worry.
Yeah.
Where I? No, it's the former, the former one. Yeah. The other one, the former. Sorry, the former one, please. Okay, we are. I'm still introducing the community health worker composition and specificities. Where I? Oh, okay. Okay. It's about as I was saying, the head of the health center. I always speak about the supervisor. Okay, we are now in career progression. For career progression, graduate AAC need to apply to another job position in health system. There is no career progression for undergraduate AAC or RC. Among graduate AAC, women are in majority. Among ungraduated, men are in majority and live and work in rural areas. Female AAC are usually married. Male AAC can be both married or unmarried. Male RC are in majority in rural areas. We don't have information concerning urban RC yet. Next slide, please. Okay. Now, provisional gender analysis. Until 2008, AAC were all undergraduated and mostly male, despite Ministry of Health decree predicts gender parity at their recruitment level. These reasons for this male bias have not yet been found. In spite of that, under the HISS program, which trained them in ICCM, a high number of female AAC were trained. However, the rate of attrition among them was much more higher than among male. The reason for such a massive abandonment by female AAC is not clear yet. Since 2008, AAC are no more recruited from their village. They are recruited by public tender and have to have a certificate degree. Graduate AAC are mostly female. Since in Niger, married female health workers cannot be deployed to rural regions without their husband's permission, most of them work in areas near urban centers. For those who cannot escape from being deployed to a rural case de santé, absenteeism tends to be high. Male and ungraduate AAC dominate the rural landscape. More, they are the only health workers category deployed to the most insecure zones of the country. Undergraduate receive less bonus based on performance than graduate AAC. For example, they are not rewarded for attending delivery because they are perceived to be unskilled to perform such clinical procedures. At first glance, female AAC seems to be privileged in relation to male. They are deployed to better areas, they work few hours per week in average, and they receive more incentive payments. However, when we analyze more carefully this aspect, we realize that the truth is that graduate women are predominant in the lower echelon of health system workforce and are paid as undergraduate health workers. while graduated men have easy access to higher and better position. Just to say that most of these women are have a nurse certificate. Furthermore, data collection during exploratory interviews have shown that female workers can be coerced by their hierarchical superiors in order to not apply to higher vacant positions. In regard to RCs, national strategic documents on community health predict gender parity among them, but this has only been achieved in Keita region. 51% of RC are female in that region. In spite of that, data collected during exploratory interview has shown that communities tend to prefer female RC. Officially, the reason for male bias is female low literacy. Even if RC just need to know how to read and write, and the schooling rate among girls has increased considerably over the last decades. In truth, it seems that community leaders usually interfere in RC selection, hampering by this way the recruitment of women. In regard to training, a gender module was planned in the curriculum, but it never got implemented. A gender-sensitive supervision was also planned, but there is no evidence. There are no evidence of having also been implemented. According to literature, ANVD supervisors tend to give better scores to male RC because of their high literacy level. ANVD supervisor, there is only three female among ANVD supervisors, and they work all of them work in the married region. Data collected during the exploratory interview has shown exactly the opposite. RC female RC tend to be more efficient than their male counterparts. Sometimes their husband may require the presence of a male parent during their supervision, especially when ANVD supervisor is a male. Retention rates among female RC are also higher. Males tend to have higher rate of attrition due to their marital economic duties. Women are a more stable volunteer workforce. RC training in ICCM should be contribute to promote more gender-sensitive policies and strategy, but it's not clear yet its impact. Next slide, please. A gender mainstream process at the sector policies and deployment programs and project level is currently in progress in Niger. The most recent National Strategic Plan for Community Health says that gender must be taken into account in all health activities and also in the community health approach to health problems by establishing equality and equity between sex, especially for indigent and other vulnerable groups. However, it's still unknown what specific measures are or will be taken to fight back gender inequality that affect both female and male CHW. Next slide, please. So the next steps regarding research in Niger. We will conduct some interviews at the institutional level with key informants in Niamey, and we will conduct interviews at community level, urban and rural areas. We will try to find other relevant documents that we not aware to, and we will collect informal sector disaggregated data at trade union level. I shall stop here. Thank you.
Paula, for your presentation. So I would like to invite the attendees to post your questions, so you can post it in the Q&A in the platform. You have any questions for Paula? Maybe you can start with a question by Mary Adley, I believe, that she had some questions in terms of the gender balance that favoring female community health workers, and if that's something that we can see in terms of the career progression. For example, Paula, do you have data about the gender of the supervisor to the palais communautaire, for example?
Yes, I was, as I said, we have regarding INVD supervisor of RCs. There are only 3 female supervisors. In regards to the others, the AAC, it's usually the head of the health centers that supervise them. So as mostly of the health centers are positions occupied by men, because graduate men usually occupy the position in the health system. Usually they are the supervisor of both women and men. I'm not hearing you.
Thank you, Paula. There's another question for Baltazar Chilundu. What type of curative care is provided by community health workers in Niger? Are they assisting pregnant women as well? And if so, is there any gender issue that is given by male community health workers?
Sorry, is a issue? Sorry, I didn't hear you.
I will repeat maybe. Is there any gender issues when the care is given by male community health workers?
Yes, there is. AAC provide primary health care and assist the deliveries of women's delivery, sorry. Yes, they are sometimes in the communities, they don't want a male AAC to attend their woman during delivery. They want they prefer a female TBA to do that, because they don't want it's not a problem among women. They don't care about that, but their husbands are not comfortable that their woman being assisted by a male, especially if he is from the community, because of the shaming. Okay.
Thank you, Paula. Is there any other questions? I don't think so. So we will have an opportunity to have a general discussion at the end, but I think we are keeping very well with time, so we can start maybe the presentation for Mozambique. Thank you, Paula. You can unmute.
Okay. Thank you.
Thank you. And I'm going to share my screen. Okay, I hope you can all see the presentation, my presentation. Okay, so I'm going just to give you a very general overview of the community health workforce for Mozambique. And we are very lucky to have also the Professor Baltazar Chilundu. So he's a professor of public health at University Eduardo Mondlane in Maputo. So he has been working on these questions of community health and workforce for several years. So we will welcome him for the discussion. So for Mozambique, the community health workforce
sorry, Claudia, this is Joanna. Can I just come in? We're seeing the it's presenter view.
Okay.
Sorry.
Thanks for telling me. What about now? Can you see also, can you see my notes?
No, you haven't screen shared yet.
Okay.
Mm-mm. Yeah, now that's perfect.
Okay, yes. So we have the overview of community health workforce in Mozambique. We have the general, we have in all the other countries two different types of cadres. So we have a more formal cadre and a more informal cadre, but there are other cadres also. It's more diversified in Mozambique compared to Niger and to Zambia. So we can think that there are these community health agents or community health workers that they are chosen by the community, they are trained by the Ministry of Health or NGOs and international or national NGOs, and also religious institutions to perform promotive, preventive and or curative activities at the community level. So as part of the community health agents, we have these different cadres that are included, the agent polyvalent elementar, that it means in English, the polyvalent elementary agent, that is the more formal cadre. And then we also have other cadres such as the traditional birth attendants, and we have activists or first aid socorrists. So to give you just an overview of all these different programs, we have the polyvalent elementary agent, that is one type of the community health worker, and that provides integrative community case management in the context of the integrated management of childhood illnesses and a broader strategy of community involvement. So this polyvalent elementary agent, I'm going to start talking in terms of acronyms, is easier, APE. So APEs are community members. They are selected by the community, by a community committee. They are trained by the Ministry of Health. The Ministry of Health in Mozambique, the acronym is MISAO, and also NGOs to provide the preventive, curative and promotional care. And in terms of time spent on curative services are 80% of the time compared to 20% in terms of health promotion. And then we have the more informal cadres, that we have the activist, the volunteer, and the traditional birth attendant. So the activist is a volunteer. So they are all volunteers, activist, volunteer, and traditional, they are all volunteers, but they receive training. So the activist is a volunteer member of the community that is also selected by the community and trained by an NGO or MISAO, the Ministry of Health, working under the guidance of and with the methodological support of NGO or state institutions. And if exists, the board of community leaders. So the activist doesn't play a treatment role. And as part of the activists, we can include three different groups. We can include the socorrist, that is a first head that is mainly works for the Red Cross. We have the animator and we have the promoter, so that they are other different names for activists depending on the regions where they work. And then we have the volunteer that is also a member of the community, is also trained, is also selected by the community. So is trained by NGOs or institution of health. So the difference for the volunteer is that it doesn't play a treatment role and there's no payment of a salary or incentive involved. And then finally, we have the traditional birth attendants that are women who assist deliveries in the community and are recognized as such by the community. So all the activist volunteers and traditional birth assistants, they receive some training that it can go up to 5 days of training, and it may involve or may not involve some payment. So the volunteers are not paid activists and traditional, as long as we know based on our review of literature, they receive some incentives. So in terms, just to give you just also a historical perspective of the community health in Mozambique. So Mozambique had several initiatives of community health care that are provided by the national government and NGOs. And between 1978 and 1988, there were about 1,500 community health workers trained. However, this was during the period of the 16 years of the Civil War, and that impacted negatively the health system and includes, for example, the facility-based healthcare services that were disrupted, and also the training program that caused the community health work training and program to lose momentum. So there was an attempt to revive the APE program in 2010 and across the country with objectives of extending the coverage of the national public health system that at that time in 2010 was below 50%, and also to improve the quality of the primary health care. So in terms of the situation, based on the latest data that we have, and this is from 2014, we can see that the figures for the health workforce indicate that there's, in 2014, about 1,600 APs working nationally, and mainly in Nampula, Sofala, and Cabo Delgado, and the majority of these APs were male. So it's the same that we observed in Zambia. So 65% are male, but there are large variations across provinces. And so we have data, sex disaggregated data and age disaggregated for Mozambique, at least for 2014. I believe that we may find more recent data. And we can see that this gender imbalance, it varies according to the provinces with a very clear pattern that is, we can find more male community health workers in the urban region, in the rural regions, and more female in the urban regions. So, for example, in Maputo, that is the capital city, so we have 90.9% of the APs are female. And in more remote districts in Sofala and Tete, we have less than 10% female. So that may be some reasons for that. So we can explore the reasons later, but I can tell you now that maybe one reason that is related with with policy is that women, if they are married and if they are family, they are allowed to accompany their husbands if they are moved to the capital. So it means that this law will create some gender biases in terms of having more female community health workers in the urban areas. There will be other reasons also for that, but that is a crucial one that we found at the beginning of the study. So in terms of the age distribution, it also varies according to the different provinces, but only looking at the percentage of female APs, they are mainly in the age group of between the 26 to the 40 years old. Okay, so in terms of the recruitment of the APs, so I'm not going to repeat this again, but they are selected from the communities, and the community need to be located between 8 and 25 kilometers from a health facility, just to allow the connection between the communities and the health facilities in terms of receiving technical support. So there's also a number for the number of APs per community. So depending on the population, so it requires a population between 200 and 500 people for that community to have APE, and the communities are encouraged when they do the selection of the candidates to have at least twice as many candidates for the selection to allow some quality poll. So the APs are expected to serve the communities they belong to, and the Ministry of Health recommends the involvement of the community in the selection of the candidates. So that implies that there is a community meeting, there's a community committee that is open for all members, and where the representatives also of the health sector participate. And there's through this community participation, community engagement, it's discussed the role and the profile of the APs, and is explained what are the characteristics that they should look for in the selection. And among those characteristics, gender, it's given priority. So the criteria for the selection is, in the first place, gender. So the Ministry of Health recommends that female candidates should be given priority. So we don't know how it works in practice, And there's also a level of education required that allow them to speak, write, and read Portuguese fluently and with basic notions of maths. So this is equivalent to the first year of secondary school or 7 years of school. So that will be a challenge for females. So the APs should also be respected and accepted by the community. They should have shown involvement in community activities in the past, willing to be APEs and available to attend training and to serve the community. So what we can see here is that even though there's an explicit criteria to give priority to women, all the other criteria can overrule the criteria for women, because women have a lower education, they will be less likely to be seen as more vocal, respected, and accepted in the community and have less involvement in community activities. And that also thinking about the social norms of in rural communities that men tend to be APEs, we may think that women will be less willing to attend training and to serve the community, as this is seen as a male role. Okay, I'm going to talk about that. In terms of training, there's also some requirements in terms of training that can discriminate against women or unfavorable to women. So for example, the training of APs is designed to last around 18 weeks. So it means that if you look at the gender, the segregation over time, so we have data for people who attend training of APs since 2010, and we can see that there's a marked bias with more male. Male are the orange and female are the blue. So there's more male attending training systematically in every year compared to female. So we can see that there's already a bottleneck here in terms of recruitment and then in terms of training. So this long and uninterrupted training and poor accommodation conditions, as they were referred by some researchers, were raised as a barrier to women joining the workforce or attending training for career progression because of the gender and household responsibilities. And so we also observe that attrition rates among male community health workers are also higher than those for female. So those who continue, they are more likely to be female than male, just because male tend to leave roles in favor of higher salaried positions, and some of them outside the country. So in terms of the policies that are relevant for the community health workforce, we identify 4 policies. We are now in the process of doing the gender analysis of these policies. We have some initial insights. So the Ministry of Health identified gender equity as one of the organizing principles of the health strategy. So this is the health sector strategic plan that goes from 2000 to 2020. So the objective is to make services more accessible and with better quality, in particular for women. And the Ministry of Health also involved a gender assessor who is a member of the National Council for Advancement of Women. And the Ministry of Health, in terms of the gender equality, has committed to integrate gender equity in health, in key processes, strategies, and programs within the context of post-Beijing action plan, the system-wide action, and the health sector strategic plan, to incorporate gender data related to access and use of healthcare in its monitoring systems, including collecting sex-disaggregated data for the health workforce, and also providing gender training to health professionals and to promote gender equality in the health services. So there's a manual of gender equality and the training of health for health workers, and also to ensure that in health services monitoring, gender questions are considered, and to promote and disseminate reproductive rights and legal measures to protect against sexual abuse, physical and domestic violence. And there was, I also, I don't know if this, when I'm presenting, this is also based in the desk review, so I really don't know if some things, they don't work like that in practice. So I really trust our national advisor to give some comments about that. But I also found some information that there are some community engagement in terms of designing the policies where young females in the communities I heard in terms of the health priorities, and this had already some positive results in terms of teenage pregnancy that has been decreasing for the fact that they were involved in the designing and the discussion of the policies. So finally, in terms of the next steps, so we are also planning to have interviews at the institutional level with the key informants and at community level, and we are also continuing to do our desk review for finding other relevant documents or policies for this study. So thank you for your time. I'm going now to switch to the platform to see if you have any questions. Feel free to ask any questions, and I will also invite Professor Baltazar Chilondo to participate in this discussion. So we have some questions here. Okay, so from Rosie Stitch. From my research in Mozambique, one of the reasons for the higher rate of women in Maputo is that there are many work opportunities in neighboring South Africa than men, and younger women take up. This leaves more women to take up the role and also gives women more autonomy to take up the role without their husbands present. Yeah, thanks, Rosie. Oh, this is a very interesting insight. Yeah, I believe that this may be one of the reasons that there will be more availability of places in the urban areas, and we indeed found some research that point to the fact that immigration will be higher among men. So thank you for your valuable insight, and also that in the north, paid APE opportunities are given to men preferentially. So interested to see if you find similar. So we believe that is the case, as this. The community committees, they have a say in who is going to be suggested for the APE program. So we believe that there will be some gender bias due to some social norms. I wonder if, Baltazar, would you like to comment in any of these questions, as I believe you have very up-to-date?
Yes. Yes, I can try to provide some of the comment. Thank you so much for this great presentation, and for all of them. We're really learning about this implication of gender on community health workers. In fact, just to correct a little bit, Maputo City does not have Ap Apes community health workers. It's the only province which is a city without community health workers. The Maputo that is mentioned here is Maputo province, which means which includes some rural districts that are surrounding Maputo City, and in fact, Maputo province and Gaza are the only province which are the most southern province, are the only province where we have more female community health workers than males, and we can have a number of explanations around that, but I would generally say the education level in general in Maputo province and Gaza, as compared to other northern and central province, is better for women, and they families tend to accept, women from, living from domestic work and participate in more kind of active work. While other provinces, particularly Sofala, Niassa, Cabo Delgado, they have so many cultural barriers there, and even the selection of community health workers, although it is clear from the government that priority should be given to women, in many of these settings, the northern settings and central settings, there are many more barriers, particularly given by the community leaders. Because the community leaders have the voice in terms of selecting community health workers who will be trained. And then they tend in those regions to select only men, instead of women. But this trend, in fact, has improved over time. In 2015, we had 29% of community health workers being women only. And this has improved now in 2019 to 40%. And provinces like Maputo, Gaza, and now Nampula as well, one of the northern provinces, now has a better ratio female to male now in 2019. And this was mainly thanks to the, I would say, obligation that is being imposed by government. You know, it's like we have to have at least 80% of women being recruited to be trained. You know, this has been the campaign now, rather than just leaving a province and district selecting by just advocating for women participating. They're really trying to impose. You know, in some provinces they are succeeding, but in some others, like Sofala, Niassa, Cabo Delgado, the situation is exactly the same as we have seen in 2014, 2016, and 2015. Just to mention some of the issues that we have. So perhaps now I can, if I'm not sure I have responded to many of the aspects, but let me see where the questions are now.
Yeah, there's one question about, does the level of education required have an impact on the quality of care, attrition, and respect from community or ability to carry out the work?
Yes, it does. You know, the community health workers curriculum has changed over time because they were assigned more activities. You know, as you have seen, they are now doing ICCM, they are treating for malaria, they are treating for diarrhea, they are treating for, they are also giving family planning implants and so on. So, so the complexity is higher, which means we need more kind of educational, better educational background. And at the beginning, it was only up to Septima class, which is level 7, you know, which is just at the end of primary education. You know, it was enough for them to be admitted. Now, from the current curriculum, only those who have level 10 can be admitted, at least from what is written, because of those areas that have been included in their training, which means to some extent, the quality of education, of course, it has to do with their ability to absorb the topics that are being addressed, and then to provide better care.
Thank you. I also read that in one of the first evaluations of the AP program that was a finding that was very relevant, that women they found the program more difficult. So in terms of their success, in terms of assimilating
Yes.
the concept of AP, there's a clear disadvantage that they begin with.
Yes.
Thank you. So let's maybe we have another question, and maybe let's close. There's another question here to say, what about the allowances for community health workers? Is it harmonized between the Ministry of Health and the NGOs? And also related to payment, yeah, like why there are no incentives for the community health volunteers? And how is it possible that they provide time and good performance without rewards?
Yeah. Good question. This is the biggest problem we have, you know, with our official payer program, the community health program, you know, because the incentives that is given from the advice of the government is just like, let me say, it's like $30, you know, $30 only. Per month, which is actually it's even less. It's 20. Yeah, it's $20. Yes, so per month. So this is very. It's almost nothing in terms of managing, you know, your day to day. And if you compare this incentive from the ones that are given by NGOs, not to APAs, but to other kinds of community health workers who are employed by NGOs, the difference is huge. There are many discrepancies. And also it's worthwhile to mention that the government is not paying to any of the community health workers, even for APAs, they are not paying. They are asking NGOs to cover salary for the APA, the official community health workers. Unfortunately, that's the picture today. Hence, the APAs, although they're earning this $20 per month, they have to seek to additional ways of surviving. So and actually this is formal. They are not supposed to dedicate their time, their time completely. They're not full-time employees as community health workers, so they have to find some. They have to find some other sources for sustaining their life.
Okay, thank you very much, Baltazar. If there's no other questions, so there's only a final question. I think maybe you answer. Can the training be adapted to the level of education of the community workers? Okay, so yeah, I think that will be a very good recommendation. Yes, that will be different tiers, probably in terms of the community health workforce training. I don't know if you have any thoughts about that, Baltazar.
At the moment, I don't have, because this is something that we discussed a lot in country, because I was the one also updating the training materials for community health workers. And the problem is, as I said, is just one curriculum. We don't have two or more types of curriculum. So for all Ap Apes doing the implementing the program, they have to have some minimum criteria in order to be able to absorb those training materials and so on. So to adapt the level of education, I don't think it will be an easy task unless we distinguish different categories of community health workers. But if we see like traditional birth attendants, we can see as community health workers. Of course, those are not required to have all those kinds of levels of education.
Okay, thank you very much. And thank you also for all your questions and for this very rich discussion. So just before we close, I just would like to let you know that there will be a second phase of this work that is a framework to incorporate gender in the health system strengthening framework based on this country gender analysis. So we will try to develop a methodology to do gender analysis of policies in other countries from the Community Health Roadmap, and also a gender framework to incorporate gender in the health systems assessment framework, building on the WHO six health system building blocks, and also the UNICEF framework of the health system strengthening. And we will develop this in consultation with a team of experts who will be convened in expert meeting in February. And this expert meeting is going to be hosted at Gender and Health Hub as part of the United Nations University International Institute for Global Health. So please follow us on Twitter or just check the website if you're interested in continuing engaging with us in this work. So thank you very much, and I wish you all a good evening.
Thank you.
Thank you.